Today I'm going to be talking about the different flushing solutions for central venous catheters. The two most common are heparin and 0.9% sodium chloride. I'll be setting out to decipher which one is better than the other based on current research. By the end of this presentation, there are some objectives the viewer will be able to meet. The viewer will be able to state the difference between Option Care's central line flushing protocol and the new protocol I have recommended. The viewer will be able to state two risks of heparin, and the viewer will be able to state whether or not current research supports the change proposed. This is the basic vascular access device flushing protocol from Option Care. A later slide will detail the specific solutions required for the different vascular access devices. This project is focusing on central venous catheters, which include PICC lines and central lines, not ports. So when I was at the hospital doing clinicals, I noticed that PICC lines were being flushed with saline. And when I started my preceptorship at Option Care, I noticed that they use nothing but heparin to maintain their central lines. So it got me wondering why, and that's what I wanted to do my project on and dig a little deeper into the reasons maybe one is chosen over the other. This is just a picture of a double lumen central line being flushed. So the population would be any client with a central venous catheter. The issue is whether or not heparin is the best choice for flushing, or if sodium chloride is just as effective. We'll be comparing current flushing policy of Option Care and current research studies comparing the two different solutions. This is the guidelines from Option Care, which actually follows the Infusion Nursing Society's guidelines as well. On the third and fourth line, it lists the PICC and central line flushing solution protocols for maintaining the line. It's 5 mils of heparin of 10 units per mil, or 3 mils of heparin at 100 units per mil. The benefits of using the best method for flushing the central venous catheter is that it would decrease complications, lessen therapy interruptions. When the catheter is occluded or not functioning properly, the patients are not getting the therapies they need, and that can cause big problems for them. It lessens the catheter reinsertions that might need to be done. It reduces the use of alteplase, which is what they use when the lines are occluded, and it reduces nursing interventions. So the two big flushing solutions are heparin and sodium chloride. Why has heparin been the solution of choice is kind of what I set out to figure out. Heparin is an anticoagulant. It decreases the clotting ability of the blood. It will not dissolve blood clots that have already formed, but it may prevent the clots from becoming larger and causing more serious problems. So it makes sense to use heparin, but it's important to know if sodium chloride will maintain the same result as heparin. So the two solutions of heparin used are heparin 100 units per mil in 3 mils, which would give us 300 units of heparin, and heparin 10 units per mil in 5 mils, which would give us 50 units. This is Oprah, and she thinks everybody should get heparin, so we'll see. Okay, so this is just 0.9% sodium chloride in a 10 ml syringe. This is how it comes. So benefits and risks of heparin flushing. The benefits of heparin are the possible reduction in lumen occlusions. Risks of heparin include heparin-induced thrombocytopenia. We'll get more into that in the next slide. Bleeding. You should not use heparin flushes if you have certain medical conditions. These would include lack of platelets in your blood, uncontrolled bleeding, and women over 60 are more likely to have bleeding episodes while using heparin as a flush solution. Other reasons heparin may not be the best solution are the cost is much higher than sodium chloride, and historically there have been heparin shortages. So heparin-induced thrombocytopenia, which is also called HIT, is a condition that causes a decrease of platelets in the blood. Platelets help the blood clot. Signs and symptoms of HIT are pain, redness, and swelling of an arm or leg, bruise-like discoloration of the skin, and weakness or numbness or problems moving the arms or legs. There are several complications of HIT, which include deep vein thrombosis, pulmonary embolism, thrombotic stroke, myocardial infarction, and limb arterial thrombosis. And HIT can occur even months after using heparin, after the heparin has been stopped. This is a picture of what HIT looks like on the hands and feet. So benefits and risks of sodium chloride. The benefits are that it's less costly than heparin, and historically there aren't the shortages that there have been with heparin. Risks are, possible increase in the risk of the occlusions of the lumen. So study results. This first one was done in 2014. It was a randomized one-way single-blinded test with a control group that was done in home care patients. The number of participants was 90, and each of the study groups had patients who experienced one or more patency-related complications. There was no statistical significance in additional factors that may affect catheter functioning, including patient age, gender, diagnosis, therapy type, frequency of catheter use, catheter brand, size or number of lumens, a concomitant use of anticoagulant medications, or whether CVCs were used for routine lab testing. The majority of their participants were receiving antibiotic therapy. The participants were divided into 3 groups, with one group of 28 participants using the SAS method, SAS, for saline antibiotic saline. One group of 30 participants was using a low heparin solution, SASH method, that was saline antibiotic saline heparin. And this low heparin group had a concentration of 10 units per mil at 5 mils for 50 units of heparin. And the last group of 32 participants received heparin at a high concentration, also using the SASH method. They had 100 units per mil, 3 mils, or 300 units. The number of days the catheter was in place was statistically significant and confirmed the assumption that the longer a home care patient's catheter was in place, the more complications occurred. Flushing frequency coincided with the medication dosing schedule, or every 12 hours. The SAS group had 9 instances of sluggishness or occlusion, with 7 of those requiring out-of-place administration. The low heparin SASH group had 8 occurrences of sluggishness or occlusion, with 3 requiring alteplase, and the high heparin group had 9 occurrences of sluggishness or occlusion, with 3 requiring alteplase. The next study was done on 84 patients. It was a double-blind study performed in an ICU with central venous catheter data being analyzed to conclude that there was no statistical significant difference regarding the effects of heparin and sodium chloride in maintaining the patency of the lumens during the 21-day study. The participants were divided into 2 groups of 42. One group was given sodium chloride and the other was given heparin. The concentration differed from 10 to 1,000 units. The exclusion criteria for this study included risk of bleeding, receiving blood products, and total parenteral nutrition during the study, and an increase in body temperature higher than 37.7 degrees Celsius. The last study I'll be referencing was a randomized trial done in 2012 comparing heparin, 3 mils, 10 units per mil, and sodium chloride flush solutions in patients in a ICU and surgical burn trauma unit in St. Louis, Missouri. The total of 341 patients were randomly assigned to receive either heparin or sodium chloride within 12 hours of their central venous catheter insertion. Assessment for patency was performed every 8 hours in lumens without continuous infusion for the duration of the placement or discharge from the ICU. The total number of lumens was 709, including catheters that were multi-lumen catheters. A total of 166 patients were allocated the sodium chloride, and 172 received heparin. One of the patients receiving the sodium chloride needed alteplase. In the heparin group, 5 patients had decreasing platelet counts, 1 had bleeding, 2 had a hip panel stent, and 1 had a mechanical obstruction from the sutures. The non-patency rate in the heparin group was 314, and the non-patency rate in the sodium chloride group was 395. So the results of the study determined that the sodium chloride and heparin flushing solutions have similar rates of lumen non-patency. There are other factors affecting the patency, which include the frequency of flushing, and these protocols differ among facilities as well. Volume flushed, also something that differs. The technique, whether or not a pulsing action is used or a slow push, and then whether or not positive pressure is maintained. The impact on nursing, there's little impact on nursing initially with regard to which solution is being used, but the risks for the patient, as stated earlier, will impact the nurse with the care that he or she gives and the amount of time spent with them. So the proposed changes to the policy on central line catheter flushing would be to maintain and lock the catheters with 10 mils of 0.9% sodium chloride every 24 hours, using a pulse-pause action when flushing, and maintaining a positive pressure in the lumen. The quality of heparin and sodium chloride in catheter function based on current research shows that sodium chloride can be used in place of heparin without any statistical significant difference. Given potential safety concerns with the use of heparin, 0.9% sodium chloride may be the preferred flushing solution for use in central venous catheters. So I've completed my presentation, and now the viewer should be able to meet the objectives outlined in the beginning of the PowerPoint. The difference I proposed is to change from a heparin solution flush to a sodium chloride flush while using a pulse-pause action This creates turbulence that's needed to clear the lumen out, as well as maintaining a positive pressure to help reduce fibrin tissues from forming at the end of the lumen. Two risks of heparin would be HIT, which is heparin-induced thrombocytopenia and bleeding. The current research findings overwhelmingly point to switching to a sodium chloride flushing solution to prevent complications from heparin, as well as save costs for the client. And this is my poster on heparin versus saline for central venous catheter flushing. Thanks for listening.